Welcome to the Neuroendocrine Cancer Foundation podcast. I'm your host, Lisa Yen. I'm the Director of Programs and Outreach, as well as a caregiver and advocate for my husband who is living with neuroendocrine cancer. In each podcast episode, we talk to an expert who answers your top 10 questions. This podcast is for educational purposes only and does not constitute medical advice. Please discuss your questions and concerns with your physician. I'm really excited to introduce our guest for today, Dr. Jerome Zacks. Dr. Zacks is a cardiologist and Carcinoid Heart Disease Specialist, retired since December of 2021, but he remains active as an Associate Clinical Professor of Medicine at the Icahn Medical School at Mount Sinai in New York City. He is a founding member of the Center for Carcinoid and Neuroendocrine Tumors at the Icahn Medical School at Mount Sinai, as well as the founder of the Carcinoid Heart Center. He formerly served on the medical advisory board of the oldest net patient advocacy organization, the Carcinoid Cancer Foundation. He currently heads the Electrocardiography course for the fourth-year medical student elective at Mount Sinai Medical Center, which has resulted in an international reputation among students seeking cardiology training in the United States. Dr. Zacks continues to devote time to the care of patients with carcinoid heart disease. He has served as a member of the Guidelines Committee for the European Neuroendocrine Tumor Society, ENETS, and of the North American Neuroendocrine Tumor Society, NANETS, and he developed a new approach to compression stockings for patients with leg edema and was granted a patent for this innovation. Along with his wife, Elena, who's a nurse, they have devoted their professional lives to patients with heart disease from rare neuroendocrine tumors. They've mentored 5 children and are now learning from them and their 6 grandchildren who have provided the real fuel and excitement for their lives. A fun fact about Dr. Zacks: at the age of 81, Dr. Zacks still barefoot water skis, and he sent us a picture to prove it. So Dr. Zacks, welcome to the LACNETS podcast, and I'm really excited to have you join us. I was wondering, as you introduce yourself, if you might share, number one, how long you've been barefoot water skiing, because that is so much fun, and also how you got into this field of neuroendocrine tumors and specifically carcinoid heart disease.
So I've been barefoot water skiing since I was a child. I guess I started doing that at about age 14 and have been doing it ever since, fortunately. And the story of how I got involved in neuroendocrine tumors is quite an interesting one and a very positive one. I was a cardiologist at Mount Sinai at the time. I had just finished my training, and Dr. Richard Warner, who's one of the early pioneers in neuroendocrine tumors, was my friend and fellow snow skier and water skier. And he asked me, would I help take care of patients with carcinoid heart disease? And I said, Dick, I don't know much about that. And he said, well, you'll learn. And I've been working with him ever since. And Dick is living in Denver right now, obviously retired. He is the most senior person in neuroendocrine tumors in the world at the present time.
Amazing story. And I remember seeing the two of you together at the Healing Net Foundation Summit where we meet, and the bond between the two of you is remarkable and special for sure.
Yes, he's like a father to me.
What a special person who really has created a legacy. Well, if you're ready, then we'll just dive into the questions. The first question is really a foundational one, and one to really understand this topic. What is carcinoid heart disease, and what causes it to happen?
So as you will see shortly, carcinoid heart disease is a receptor-mediated disease. Carcinoid heart disease is, in 95% of cases, a receptor-mediated valve disease. In only 5% of occurrences, is it metastatic tumor within the heart. So carcinoid heart disease is usually due to a high concentration of liver metastases which secrete vasoactive substances, including serotonin, which is carried in platelets into the blood, which then flows via the inferior vena cava right into the right side of the heart, where serotonin receptors on the inner lining of the heart stimulate fibroblast proliferation, which is just a fancy term for scarring of the inner lining of the heart. And then the scarring actually continues throughout the right side involving the right atrium, the tricuspid valve, the pulmonic valve, and into the pulmonary artery leading to the lungs, where serotonin is then deactivated in the lungs. And this actually prevents the blood from going on and affecting the left side of the heart, including the mitral and aortic valves, from having carcinoid heart disease. So carcinoid heart disease is usually a disease of the right heart valves, the tricuspid and pulmonic valves.
Wow, thank you for that really clear explanation. So I hear a couple things that serotonin is the culprit. It usually happens when there's liver metastasis and it affects the right side. So a couple questions with that. One is, does it ever happen without serotonin being high, without serotonin being the culprit?
So actually, we're going to comment more about that coming up, but the answer is yes, but it's rare.
Okay, we'll discuss that a little bit more later. And then also, does it ever happen when there are not liver metastases?
Yes, another great question. And I had planned on discussing that whole issue because it's such an important one. The short answer is if you don't have any liver metastases, but you have carcinoid heart disease, then look for an ovarian carcinoid because that blood drains directly into the inferior vena cava and bypasses the liver and goes directly to the heart.
A strong pearl there, and we can always circle back to this. And so, Dr. Zacks, the second question on this topic is carcinoid heart disease related to carcinoid symptoms? And serotonin being high, if my symptoms are not controlled, does that mean I might develop carcinoid heart disease?
Yes, roughly 50% of patients with the carcinoid syndrome will develop carcinoid heart disease during the course of their disease. Carcinoid heart disease occurs in patients with the carcinoid syndrome, which is usually flushing, diarrhea, and the carcinoid valve disease. Flushing is due to the histamine effects of the tumors. Diarrhea and carcinoid heart disease are due to the serotonin effects. And it should be noted that serotonin is a crucial stimulant of normal bowel motility, acting via serotonin receptors in the bowel. However, in gastrointestinal carcinoid gnats with the carcinoid syndrome, the excessive serotonin from the tumor overstimulates the serotonin receptors, especially in the small intestine, causing diarrhea.
Oh, that's really interesting. A really important note that we need some amount of serotonin, but in this case, it's overactive. So if the symptoms are uncontrolled, does that mean I might develop carcinoid heart disease?
Indeed, there is a correlation of serotonin-related symptoms and the likelihood of developing carcinoid heart disease.
Okay, that's an important point to control the symptoms, and I'm sure we can circle back to that. So, Dr. Zacks, how concerned should I be about developing carcinoid heart disease?
It's important to check NET markers, which are pancreastatin, NT-proBNP, and plasma 5-HIAA or plasma serotonin. If the BNP, 5-HIAA, or serotonin is elevated, one must rule out carcinoid heart disease with an echocardiogram. And the echocardiogram is one of the few tests that's 100% sensitive and specific for carcinoid heart disease.
The echocardiogram is the gold standard. So that means if it's 100% sensitive and specific, does that mean a normal echocardiogram would rule out carcinoid heart disease?
That's correct.
Okay, that's helpful. Which patients end up getting carcinoid heart disease?
Those with elevated serotonin. Maria Spatz in 1964 demonstrated in a guinea pig model that there are 3 essential requirements for the development of carcinoid heart disease. First, a high serotonin in the blood. Second, a relative tryptophan deficiency. Tryptophan is the building block for serotonin. And the third is liver damage, which in humans is referring to the tumor in the liver.
We're learning a lot here about how the body works. And so Is carcinoid heart disease inevitable for patients with neuroendocrine tumors?
Not all patients with high serotonin levels develop carcinoid heart disease. However, nearly all have liver metastases. If a patient with carcinoid heart disease has no liver metastases, but they do have carcinoid heart disease, then you have to search for an ovarian carcinoid, which bypasses the liver and drains directly into the inferior vena cava, or rarely a bronchial carcinoid, which drains into the superior vena cava into the right heart.
Thank you for educating us that it can come from other sources, including the ovary or the lung. Is it more common with NETs of the small bowel?
Yes, because the venous blood flow route to the liver enables the blood to carry tumor cells into the heart, toward the heart, but through the liver, which filters the blood.
And when you talk about looking for an ovarian carcinoid or bronchial carcinoid, are you talking about those being the primary tumors or any tumors in the ovaries or lungs?
Well, it could be either one. In the case of the bronchial, it's usually a primary. In the case of an ovarian, it could be primary or metastatic from the abdomen.
And do those with NETs whose primary origin is from the pancreas or other types of neuroendocrine tumors ever get carcinoid heart disease?
Yes, but infrequently, in less than 10%. And approximately 20 to 50% of those with the carcinoid syndrome will then go on to develop carcinoid heart disease.
Thank you for this overview of who gets it. To kind of tie this section together, who do you think should get screened for carcinoid heart disease?
I've always been an advocate of advising people to get an echocardiogram in any neuroendocrine tumor patient. And as we go on, I'm going to explain why.
So now that we've talked about who might develop carcinoid heart disease, what are some of the signs and symptoms of carcinoid heart disease?
Typically, they are the symptoms of right heart failure due to the tricuspid and pulmonic valve thickening, scarring, and retraction, which causes the narrowing and leaking of the affected valves, which then causes an increased pressure in the inferior vena cava, which in turn causes liver congestion, with resultant backup of pressure all the way down to the lower extremities, your feet and your ankles, manifesting as edema, which is fluid in the tissues of the ankle, the legs, the thighs, and ultimately forming abdominal fluid, which is ascites. Then, if it continues to go untreated, it rises to the level of the lungs, and fluid forms around the lungs, which we call a pleural effusion. The resulting symptoms of right heart failure are the excessive fluid, the complaint of fatigue, and shortness of breath.
Yeah, fatigue, shortness of breath, and fluid that might show up in your legs and your belly. And just to clarify, Dr. Zacks, if people have some of these symptoms, does it mean it's carcinoid heart disease or could it be from other things?
That's a great question. It could be from other things as well, because right heart failure is a fairly common type of heart failure, usually in patients who first have left heart failure. In other words, a problem with the valves on the left heart or a poorly functioning heart.
Okay. So while these symptoms may be from carcinoid heart disease, it could also be from other things.
Yes.
Okay, thank you for that. So how is carcinoid heart disease diagnosed?
So the echocardiogram is deemed 100% sensitive and specific in making the diagnosis of carcinoid heart disease, assuming the test is performed by an echocardiographer with extensive experience in evaluating this disease. Of course, having elevated carcinoid heart disease blood markers, pancreastatin, NT-proBNP, plasma serotonin, or 5-HIAA, would support the diagnosis of carcinoid heart disease.
That's helpful. So you've named a few tests, the echocardiogram and some blood markers, but really that echocardiogram is the gold standard.
That's correct.
How does someone know if they have carcinoid heart disease?
Well, first, if one has the carcinoid syndrome, flushing, diarrhea, and swelling of the legs. Second, if one has fatigue or shortness of breath. Third, if one's physician told the patient they have a new heart murmur. Fourth, if the blood markers and the echocardiogram suggest it. And fifth, in cases where all of the above exist, but no one believes it. If there's a little sign on the patient's forehead that says CHD, then it's likely they have it.
Thank you, Dr. Zacks, for that and for delineating the things to look for. So, you mentioned a heart murmur. What is a heart murmur and how is it related to carcinoid heart disease?
Not all people with carcinoid heart disease have a murmur which is detectable. And not all patients with the carcinoid syndrome have carcinoid heart disease. The murmur could be due to something other than carcinoid heart disease.
And what is a murmur and how is it detected?
Well, a murmur is the sound one hears with a stethoscope if you have turbulence within the heart. That's how we diagnose clinically valve disease in the heart. However, with right heart murmurs, they're often very soft. And so sometimes we miss them.
So we may or may not hear that.
That's correct.
And what's the appropriate testing for carcinoid heart disease? I know you've touched on this, but really to help us understand, what is the testing?
Well, first, of course, is a careful history and physical exam by the physician, searching specifically for signs and symptoms of carcinoid heart disease. Second, any neuroendocrine tumor patient should have a baseline echo, not only to exclude carcinoid heart disease, but to assess the cardiac function and exclude any other valve disease. Remember, one is dealing with a disease which often is treated with surgery, chemotherapy, radioisotope therapy, etc. Therefore, it's prudent to assess one's cardiac function at the outset, and many lives are saved by taking this step early on. Third, any neuroendocrine tumor patient with symptoms of flushing and diarrhea should be tested for pancreastatin, which is the breakdown product of chromogranin A, but it's more sensitive and specific for NET, and it's unaffected by PPI medications. Also, NT-proBNP, which is an indicator of an elevated right heart pressure, and it correlates with the presence of carcinoid heart disease. And also plasma 5-HIAA or serotonin. The 5-HIAA is a serotonin breakdown product. So you can measure either one to look for serotonin elevation.
Thank you for that overview. So some people may ask, I get my urine 5-HIAA done. Should I get the plasma one done instead?
That's a great question because the urine collection is a 24-hour collection. You collect it all day long in a container. You may throw it into your refrigerator. You may end up spilling some, and then you carry it to the doctor's office, and they may throw it in the refrigerator, and they may spill some. By the time it gets to the lab, it may not be an accurate representation. And it's very difficult for a patient to do that. And so now they've proven in studies that the plasma 5-HIAA is probably even more accurate than the 24-hour collection. That's why I didn't mention it in my comments above.
Okay, so plasma 5-HIAA is your preferred test. And so you mentioned the echocardiogram is the gold standard, the 100% sensitive and specific. And of the other tests, which ones are the blood tests that can be done? And I guess also wondering, can anyone order these tests?
So the London group showed very cleverly, knowing that in heart failure the BNP is high, there are two tests, NT-proBNP and regular BNP. They are actually two different halves of the same molecule. So sometimes I'll refer to one and sometimes the other. And to my understanding of the chemistry, it probably doesn't really matter if your doctor did one or the other, although in the literature, they seem to prefer the NT-proBNP. So the NT-proBNP, the serotonin, and 5-HIAA are all blood tests for carcinoid syndrome and carcinoid heart disease.
Okay, thank you. And Dr. Zacks, for people who don't have access to a net expert, can anyone order these tests?
Yes, anyone can order them, and most of the major national laboratories will be able to perform the tests or get it done by mailing it to another lab.
So, if someone had a normal echocardiogram, 5-HIAA or serotonin, and a normal pro-BNP, could they still have carcinoid heart disease?
It's very unlikely, very, very unlikely. The exception would be due to the echocardiographer not having the experience with imaging the right heart.
Thank you for that clarification and reassurance as well. So, if someone is found to have neuroendocrine cancer or neuroendocrine tumors and carcinoid heart disease, what is the treatment approach to this?
If one has carcinoid heart disease, the first goal is to medically treat any signs of heart failure using a diuretic and blood pressure medications and addressing any cardiac rhythm abnormality.
And when you talk about addressing the carcinoid heart disease, I guess which do you treat first, the tumor or the carcinoid heart disease, and why?
The question of which to treat first, the tumor or the carcinoid heart disease, is actually a fairly easy question to answer if one focuses on the pressure in the inferior vena cava, which can be determined from the echocardiogram. If the diameter of the inferior vena cava does not vary with patient respiration, that implies an abnormally high inferior vena caval pressure, which in turn indicates an abnormally high blood pressure in the liver, which signals a high risk of bleeding if an abdominal surgical procedure were to proceed prior to fixing the heart. Thus, it's prudent to fix the heart first if the pressure is elevated. Only if medical therapy can restore a normal inferior vena caval pressure would it be okay to proceed with an abdominal surgical procedure prior to fixing the heart valves.
Makes sense. So, fix the heart, then address the tumors. So, Dr. Zacks, what is the treatment for carcinoid heart disease and how is this determined?
So, the initial treatment of carcinoid heart disease is often the treatment of any heart failure with diuretic and other antihypertensive medications. Next is usually surgical replacement of any damaged valves.
Replacing the damaged valves and then also taking out the fluid with the diuretics and medications. So, if the valve replacement's done, how many valves are usually replaced and which valves might need to be replaced?
So the two right heart valves, the tricuspid and pulmonic, are the most commonly damaged valves, and they're usually replaced at the time of surgery. If the left heart valves, the mitral and aortic, are involved, one must search for the most common causes. So the first would be looking for a patent foramen ovale, which is a persistent hole between the right and left atria, usually from birth, and it's detectable with a microbubble solution, which is injected at the time of an echocardiogram. The second thing to look for is a bronchial carcinoid tumor, which drains via the pulmonary veins into the left heart. Or the third is a very high circulating serotonin level, which overwhelms the lungs' capacity to deactivate the serotonin in the pulmonary arteries. Serotonin is primarily deactivated in the lungs at the level of the pulmonary arteries, specifically within the endothelial cells lining the vessels, where it is taken up by the serotonin reuptake transporter. They refer to that as the SERT, and subsequently metabolized by the enzyme monoamine oxidase inside the cell. This process is crucial for regulating blood pressure within the pulmonary circulation.
The two right heart valves, tricuspid and pulmonic valves. And if there's issue with other ones, then you look for a hole, the patent foramen ovale with a bubble study, or a lung tumor, or very high serotonin.
Exactly.
Thank you. So we're looking at the two right heart valves, the tricuspid or pulmonic. And when these valves are replaced, what types of valves are generally recommended? And how is this done?
So the choice is between a bioprosthetic tissue valve, which is created from the pericardial tissue or from the valve tissue from either a cow or a pig, or a mechanical valve, which is produced from metal and carbon. The tissue valve often does not require an anticoagulant medication, which would raise the risk of bleeding, especially if further procedures might be needed. The mechanical valve might offer a longer functional life, but requires anticoagulation with the anticoagulant Coumadin. Surgery is done either via a vertical sternal incision directly over the heart. This incision involves splitting the sternal bone, which is the breastbone, then resuturing it following surgery. Or a mini incision between the left ribs, or robotic surgery can be done via 5 small incisions in the right chest wall. And surgery is usually done under general anesthesia.
When surgery is done, would both valves be replaced at the same time as well as possibly plugging the hole?
Exactly. Everything should be done at the time of surgery, and usually we are able to anticipate how much surgery will be required ahead of time, although the surgeons will tell you that at the time of surgery, sometimes they change the plan depending upon the visual extent of disease.
Also, one more follow-up. I know you mentioned 2 right heart valves, the tricuspid and pulmonic. Is it possible to only need to replace one, or are both usually replaced?
So at the time of surgery, sometimes it's decided, well, actually, the tricuspid valve is severely damaged. The pulmonic valve has very minimal changes, so we'll make the surgery easier and less risky by just replacing one valve.
Thank you. So we've talked about the treatments for carcinoid heart disease. And so the next question that comes up often is what screening should be done for carcinoid heart disease, and how often should someone get screened?
The initial screening echocardiogram should be done in any patient diagnosed with a neuroendocrine tumor. And if normal, and if serotonin level is normal and remains normal, at the discretion of the treating physicians thereafter, they can decide how frequently to rescreen, perhaps annually, as I would recommend. However, they may decide it's not necessary to do it so often if the patient doesn't have any hypertension or heart failure or any other valve involvement. However, if the patient's serotonin level is abnormally high and or the patient has carcinoid heart disease, serial echocardiogram should document serial changes every 3 to 6 months if the serotonin remains elevated, or every 6 to 12 months if the serotonin is no longer elevated.
So everyone should get an echocardiogram when diagnosed with NET and also a screening serotonin. How about 5-HIAA?
Indeed, if somebody has any symptom of flushing or diarrhea, or if they have carcinoid heart disease, of course, they should get their markers drawn.
How can I prevent carcinoid heart disease from happening?
If one has a functional NET, the usual first step is surgical removal of all tumor that's possible to be removed, and with post-surgery monitoring of the NET markers, as well as serial special imaging to see if there is any regrowth of tumor. If the serotonin is elevated, treat with telotrestat ethyl. Although nearly all NET patients are treated with a somatostatin analog, either octreotide, lanreotide, or in Europe, pasireotide, which serves to inhibit the release of tumor vasoactive amines, including serotonin and histamine. If the serotonin level is abnormally high, the patient should be started on, in addition to the somatostatin analog, tryptophan hydroxylase inhibitor, which is called telotrestat ethyl. It's the brand name Zermelo, which blocks the enzyme catalyzing the first step in the conversion of tryptophan to serotonin. Then follow the serotonin level every 3 to 6 months thereafter.
So you're saying treating the tumor, cutting out the tumor, or treating it with medications helps prevent carcinoid heart disease.
Correct.
And the follow-up question to this, is it possible to reverse the damage that's been done on my heart already if I'm showing signs of carcinoid heart disease on my valves, on the echocardiogram?
So unfortunately, although there's one report of a patient who got better with just treating the heart failure, I attributed the improvement not due to reversing the scarring of the valve, but rather to the more adequate treatment of the heart failure. Unfortunately, the scar tissue does not reverse by giving any medication, even by giving telotrestat ethyl, the Zermillo. It doesn't really reverse that plaque.
Can it be prevented from getting any worse?
Only in the sense that if you are able to reduce serotonin to normal, the stimulus for further scarring is inhibited.
So we can't reverse damage that's been done, but we can stop the process from getting any worse.
We believe that we can stop the process. However, we need more studies to prove what I'm saying is actually true.
Okay, need more studies. So what kind of doctors treat carcinoid heart disease?
So here I'll begin by saying, do not leave your primary care doc or your local oncologist if they indicate they are willing to be on a team caring for you. It's prudent to seek out a NET specialist, usually an oncologist, endocrinologist, surgical oncologist, or gastroenterologist specializing in NETs for an initial evaluation. That physician will then help select any other specialists which are required to optimally care for you. NET specialists often coordinate care while also communicating with your primary care doc as well as your local oncologist. This is the optimal way to do it.
Wow, to have a coordination of care and a multidisciplinary team. So, Dr. Zacks, how do I know I'm with a specialist and specifically with one that understands carcinoid heart disease?
So ask your local docs if they specialize in NETs. If not, then either LACNETS and Carcinoid Heart Foundation, NANETS, which is the North American Neuroendocrine Tumor Society, ENETS, the European Neuroendocrine Tumor Society, maintain lists of NET specialists in the U.S. as well as internationally.
Yeah, so talk to people both in the advocacy world and the medical societies.
I'll just add one additional thing. If all else fails, look me up, give me a phone call, and I'll help you navigate.
So we can reach out to you directly.
Yes, absolutely.
Thank you so much. You may have people calling you. So, Dr. Zacks, as the final question, I'd love to hear from you what you see as the future of carcinoid heart disease management and treatment.
In 2016, we demonstrated a nearly 50% incidence of recurrent fibrosis in carcinoid heart disease patients within 2 years of valve surgery if they receive bioprosthetic tissue valves. We are waiting for data indicating whether or not telotrestat ethyl prolongs survival and/or prevents recurrent prosthetic valve disease in patients who receive bioprosthetic valves for carcinoid heart disease, and the relationship of the response to serotonin levels. So those studies will be crucial. Knowing of the relationship of carcinoid heart disease and serotonin, and of the relationship of increasing serotonin to increasing mortality, it seems prudent to recommend the use of telotrestat ethyl to reduce the frequency and extent of diarrhea, as well as attempting to prevent carcinoid heart disease in patients with the carcinoid syndrome. Also, to prevent recurrent heart disease in patients with newly implanted bioprosthetic valves, but persistently elevated serotonin. It should be noted in light of the Mayo Clinic data suggesting that recurrent bioprosthetic valve lesions following valve replacement for carcinoid heart disease might represent blood clot or thrombus, as opposed to recurrent carcinoid-induced plaque or fibrosis. So anticoagulation with warfarin is warranted with close echocardiographic monitoring of the affected valves if you see recurrence. It would also seem prudent to continue all measures to reduce serotonin to normal limits using all the available modalities, including somatostatin analogs, surgical tumor resection, tumor ablation, radiofrequency microwave cryoablation, hepatic artery embolization, either bland or radioisotope embolization, or chemoembolization through the hepatic artery, and chemotherapy. we must think of all the ways of reducing serotonin to prevent carcinoid heart disease. And finally, I want to comment on my hope for further improvement in the surgical management of carcinoid heart disease. Because often we are referred patients when their disease is advanced and their carcinoid heart disease is severe, rendering those patients very high-risk candidates for surgery. So I'm hoping that these patients will become candidates for either mini-invasive robotic surgery to diminish the trauma and attendant operative risk. And I expect also that current efforts to perfect primary transcatheter valve replacement will offer options for these patients. Transcatheter valve and valve replacement is already an option for patients with recurrent valvulopathy following bioprosthetic valve replacement. I'm hoping that all of these will be improved so that a person contemplating surgery, if they're very sick, can still have the option.
Yeah, so options without having to cut open the chest and have major surgery, but instead do it in a minimally invasive way. Could you clarify what transcatheter valve replacement is?
Yes, believe it or not, they've developed complete valves which can be folded up and put into a small catheter and shoved all the way in place inside the heart into position right inside a diseased valve and then expanded into a full-size valve and functioning immediately. It's just incredible.
That is amazing. So I know that I've heard of this being done and we're seeing it in our community as well. Locally, for me, I live in Los Angeles. For us, we have a center that does it nearby.
Can you imagine getting a new valve and going home the next day? That's the way it works.
That's amazing. That revolutionizes everything.
Yes,
So you're saying really to focus on decreasing serotonin in the whole body, the whole person care with other ways to reduce serotonin, and then hope for the future with more minimally invasive treatments. So you can go on and live your life and do things you enjoy, like barefoot water skiing.
exactly. I might just make one other comment which might be helpful, and that is to just remind people that when you have a primary tumor, in the case of carcinoid heart disease, that primary is often in the small intestine at what we call the terminal ileum. That primary tumor can be tiny, tiny, but it can spread in three major ways. It could spread locally by just growing, and it could cause an obstruction in the bowel. Or it could spread via the lymphatics to the lymphatic nodes nearby, which we call the regional lymphatics. Or the third way is the way that it gets to the heart. It can spread via the bloodstream, going to the liver and then on to the heart. It's sort of helpful to think, well, how are some people experiencing bowel obstruction? Other people are experiencing regional tumor in the abdomen, or some via the bloodstream, they have it in the liver. I just wanted to make clear so that people understood why are they talking about different problems in different neuroendocrine tumor patients.
That's helpful to deepen our understanding so we understand the physiology of it and the mechanics and how this is happening to some people and not others. And this is why each person's unique and the care is individualized.
Exactly.
Thank you for this very informative time. We're honored to have you share with us and to learn from you as you're the father of carcinoid heart disease. And this is an area that really needs more attention. And we appreciate all you've done these decades to bring attention to the field, to grow the field, and hopefully continue to move the field forward.
Well, it's been my pleasure, and thank you for inviting me, and thank you for spreading the word so that more and more physicians, patients, and caregivers will understand this disease.
Dr. Zacks, I'll end with this. If you had a magic wand and could wish for anything in this field of carcinoid heart disease, what would be your wish?
You know, I keep thinking to the underlying mechanism, what's causing it. And so I am very hopeful that the bench scientists and the oncologists and those who are working at the magic bullets to stop tumor growth or to prevent tumor growth, I'm hopeful that that's the level in which this will be solved. in addition to the whole team of people working on caring for carcinoid heart disease and for neuroendocrine tumors in general.
Yes, stopping it really where it starts, understanding where it starts and stopping it at that point.
Exactly.
Well, thank you for your insights. Thank you for all your time. Thanks for your career dedicated to carcinoid heart disease patients and the care of the neuroendocrine tumor patients as a whole. We really appreciate you. Thanks for listening to the Neuroendocrine Cancer Foundation podcast. We want to thank our podcast supporters, Novartis, Ipsen, Exelixis, Curium, Tercera, ITM, Resolute, Interscience Institute, and Boehringer Ingelheim. For more information about neuroendocrine cancer, go to ncf.net. We depend on donations to bring you programs such as this podcast. Please consider making a donation at ncf.net/donate.